Man, age 68, PSA 8.1, sitting in urologist's office expecting biopsy recommendation. Doctor reviewed his chart, PSA history, prostate exam, age, overall health, then said something unexpected. Before we discuss biopsy, let me tell you what I'd tell my own father if he had your exact numbers. Man surprised. What do you mean? Doctor, my father is 70. If his PSA was 8.1, I wouldn't rush him to biopsy. Here's why. You're 68 years old. Your PSA has been stable between 7.8 and 8.3 for 3 years. It's not rising rapidly. Your prostate on exam is quite large, probably 75 to 80 grams. That means your PSA density is around 0.10 to 0.11. That's reassuring. Your free PSA ratio is 21%. That puts your actual cancer probability around 20%, not 50%. If you were 55 with these numbers, I'd recommend biopsy today. But at 68 with stable PSA, large prostate, decent free PSA ratio, we have time to be strategic. Man, so what would you tell your father to do? Doctor, get MRI first. If MRI shows suspicious area, we do targeted biopsy of that specific spot. If MRI is clear, we monitor closely with PSA every 3 to 4 months. This approach prevents unnecessary biopsy if prostate looks normal on imaging. And if we do biopsy, we're targeting the right area, not shooting blind. Man, why didn't you start with this explanation? Doctor, honest answer. Because I have 15 minutes per appointment. Insurance pays same whether I spend 5 minutes or 25 minutes. Most doctors give the standard recommendation, PSA 8, you need biopsy. But if you were my family, I'd take time to explain context. Your age matters. Your PSA trend matters. Your prostate size matters. The complete picture matters. Man got MRI, showed no suspicious lesions, has monitored PSA for 2 years. Remains stable 7.9 to 8.2. No biopsy yet. May never need one. Study from European Urology, MRI before biopsy, in men with PSA 4 to 10 prevented 27% of biopsies, while missing fewer than 2% of clinically significant cancers. Today, we're revealing what doctors know, but often don't have time to explain. What context matters at PSA 8? What questions to ask? What options exist beyond immediate biopsy? Because PSA 8 at age 60 plus isn't automatic biopsy. It's starting point for informed conversation. 7 things doctors wish men over 60 knew about PSA 8. Starting now. Before we continue, quick reminder. This is educational information only, not medical advice. Always work with your doctor before making any decisions about PSA or biopsy. And if you want a free PSA conversation guide, the exact questions to bring to your next appointment, drop the word guide in the comments below. Now, let's get into all 7. Thing 1, the number alone means nothing. PSA 8 sounds alarming, but urologists don't look at the number alone. They look at 4 things together. First, PSA trend. Is it rising fast or staying stable? A PSA that jumps from 4 to 8 in 1 year is very different from a PSA that moved from 7.5 to 8 over 3 years. Second, prostate size. A large prostate naturally produces more PSA. A man with an 80-gram prostate and PSA 8 has very different risk than a man with a 25-gram prostate and PSA 8. Third, free PSA ratio. Total PSA includes both bound and free PSA. Higher free PSA ratio, above 25%, suggests benign enlargement, not cancer. Lower ratio, below 10%, raises concern. Fourth, age. PSA 8 at age 55 carries different weight than PSA 8 at age 72. The number is just the starting point. Context is everything. Thing 2, PSA density changes the entire calculation. Most men have never heard of PSA density. Most appointments never mention it. PSA density is your PSA divided by prostate volume measured on ultrasound or MRI. PSA density below 0.15 is generally reassuring. Above 0.15 raises concern. Here's why this matters practically. Man A, PSA 8, prostate volume 80 grams. PSA density equals 0.10, low concern. Man B, PSA 8, prostate volume 30 grams. PSA density equals 0.27, higher concern. Same PSA number, completely different clinical picture. A 2022 study in the Journal of Urology found PSA density was more accurate than PSA alone in predicting high-grade prostate cancer in men with PSA between 4 and 10. Ask your doctor, what is my prostate volume and what does my PSA density tell you? Thing 3. MRI-first is now standard of care. 5 years ago, PSA 8 meant immediate biopsy in most urology offices. That has changed. The American Urological Association now recommends MRI before biopsy in many men with elevated PSA, not as optional extra, as preferred approach. Here's why. Traditional biopsy takes 12 random tissue samples from the prostate. Random, not targeted. MRI identifies specific suspicious areas. Targeted biopsy then samples exactly those areas. Result: higher detection of clinically significant cancers. Fewer biopsies of insignificant findings. Fewer unnecessary procedures overall. The Precision trial published in the New England Journal of Medicine found MRI-targeted biopsy detected 38% more clinically significant cancers than standard biopsy, while detecting 89% fewer insignificant cancers. If your doctor recommends immediate biopsy without MRI discussion, ask, should we consider MRI first? Thing 4. Velocity matters more than the number. PSA velocity means how fast PSA is rising over time. Research consistently shows PSA velocity predicts cancer risk better than any single PSA reading. PSA rising more than 0.75 points per year is considered significant. PSA rising more than 2 points per year requires urgent attention. PSA staying stable, even at 8 or higher, carries very different risk profile. A landmark Johns Hopkins study followed men with elevated PSA for 15 years. Men with low PSA velocity had cancer-specific survival rates above 94%, even without immediate treatment. This is why your PSA history over multiple years matters enormously. One reading is a snapshot. Trend over time is the real picture. When you go to your appointment, bring every PSA result you have, dates and numbers. Velocity calculation changes the entire conversation. Thing 5. 2 conditions inflate PSA and have nothing to do with cancer: prostatitis and benign prostatic hyperplasia, BPH. Both elevate PSA significantly. Prostatitis is prostate inflammation, often from infection or irritation. Can raise PSA from baseline by 2 to 10 points. Temporarily, completely reversible. BPH is simple prostate enlargement without cancer. Affects over 50% of men over age 60. Directly raises PSA because larger tissue produces more PSA. Here is the practical problem. A man with PSA 8 from BPH and prostatitis looks identical on paper to a man with PSA 8 from early cancer. A 2021 study in urology found that among men biopsied for PSA between 4 and 10, nearly 40% had no cancer found. Many of those elevated PSAs were from BPH or inflammation. Before biopsy discussion, ask, could my PSA be elevated from prostate size or inflammation? Should we rule that out first? Thing 6. What you do in the 48 hours before the test affects the number. This surprises most men. Several common activities temporarily elevate PSA. If you do them before your blood draw, your result reads artificially high. Sexual activity raises PSA for up to 48 hours. One study showed ejaculation raised PSA by an average of 0.8 points. Vigorous exercise, especially cycling, can raise PSA for 24 to 72 hours. Cycling pressure on the prostate area is the main factor. Prostate exam or cystoscopy performed shortly before blood draw also temporarily elevates PSA. Standard recommendation from the American Cancer Society: avoid sexual activity and vigorous exercise for at least 48 hours before PSA test. Have blood drawn before any prostate exam during the same appointment. If your doctor didn't mention this before your last test, your 8 might have been a 6 point something on a clean day. Ask, should I retest under controlled conditions before we make any decisions? Thing 7. Active surveillance is a legitimate medical strategy. This is what doctors tell their family members that they often don't have time to explain in a standard appointment. For many men over 60, with PSA in the 7 to 10 range, stable trend, low PSA density, and no suspicious MRI findings, active surveillance is a medically sound choice, not ignoring the problem. Active surveillance means structured monitoring with PSA every 3 to 4 months, annual MRI, and biopsy only if specific trigger points are met. A landmark study from the New England Journal of Medicine followed over 1,600 men with localized prostate cancer for 10 years. Men on active surveillance had prostate cancer-specific survival of 99%, identical to men who received immediate treatment. Active surveillance preserves quality of life, avoids treatment side effects, and catches progression early if it occurs. The question isn't always, do I need treatment now? The question is, what monitoring plan gives me the best information to make the right decision at the right time? PSA 8 is not a diagnosis. It is not a verdict. It is a signal that deserves a complete conversation, not a 5-minute appointment ending in a procedure referral. 7 things doctors wish they had time to tell you. 1. The number alone means nothing without context. 2. PSA density changes the entire calculation. 3. MRI-first is now standard of care. 4. Velocity matters more than any single number. 5. BPH and inflammation inflate PSA without cancer. 6. What you do 48 hours before the test affects the result. 7. Active surveillance is a legitimate medical strategy for many men over 60. You now know what a urologist tells his own father. Use that knowledge in your next appointment. If this helped you, share it with one man over 60 who needs to hear this. It might change how he approaches that conversation. And if you want the free PSA conversation guide, exact questions to bring to your doctor, drop guide in the comments right now.